So hi everyone, my name is Madani. I'm a PGY2 EM resident here at Kings County, and on today's small talk series, I'll be discussing neutropenic fever. Uh, let's start by defining neutropenic fever. So a simple way to start is by breaking the terms down and defining them. We'll start with neutropenia, which is defined as an absolute neutrophil count less than 500 cells per ml, or less than 1,000 cells with an expected decrease to 500 cells. I remember reading this and thinking, how we can actually determine this expected decrease. And essentially, it's just pointing to the fact that patients who are receiving chemotherapy will have a nadir, or like the lowest point of their decrease in neutrophil count will be within 7 to 14 days after receiving chemotherapy. So if you're seeing someone, 4 days out from chemotherapy or 5 days out and they're already, close to 500, then or close to 600 or something, you can expect that it's going to be much lower in another 3 or 4 days as they progress. You can calculate the absolute neutrophil count. It's by taking the percent mature neutrophils plus the immature neutrophils, which are the band cells, and multiplying it by the white blood cells to get your number there. Fever is defined as a temperature of 101 degrees Fahrenheit or a sustained of 100.4 degrees for at least an hour. On the topic of temperature, by the way, just remember that in patients in which you're suspecting a neutropenic fever, you should always avoid a rectal exam and rectal temp, as these can be lead points for infection, more specifically, potential neutropenic enterocolitis. So what are the causes of neutropenic fever? We can think about immunosuppression. So we're thinking about myelosuppression caused by medications or malignancies such as ALL, AML, myelodysplastic disease, or advanced lymphomas. We can think about medication use, more specifically chemotherapy use, and even infection sometimes can lead to, or infection in the setting of these disease processes can also lead to neutropenic fever as well. When we think about causes of infection, we should always consider gram negatives and gram positive infection, most importantly, Pseudomonas. For gram positives, you can think about Staph aureus, Staph epidermidis, and Streptococci. You can think about fungal infections such as Candidal and Aspergillus. And then, I just brought back some of the sketchy micro for us here because when I walk into patients' room, all I see are cartoons, and it works. So I run with it. We have chemotherapy as well. In respect to chemotherapy agents, I just wanted to list some of the drug classes that we have. We have the anthracyclines, the cisplatin, ifosfamide, cyclophosphamide, etoposide, and cetirizine. I think we're more likely to encounter some of these on the downstate side, at least from what I've seen. And also just keep in mind how much damage these drugs can cause. A lot of these are interfering with cell cycle progression, and these patients really do get like pretty bad systemic effects, such as like cardiomyopathies, pancytopenias, skin changes, and essentially pretty bad side effects. So just always keep that in mind with these drugs. How do these patients present, and what should we watch out for? A good example would be potentially like a 63-year-old male with a history of AML who presents with complaints of a day of fever to 102. And we hear about chemotherapy that was started 1 week ago prior to the presentation, and then obviously laboratory findings that show a decrease in the absolute neutrophil count. So you want to consider this in patients who just recently started chemotherapy, patients with recent viral or bacterial infections, and patients receiving hematopoietic cell transplants for aplastic malignancies or thalassemias, and also just considering new diagnoses of malignancy. So just like, when you're getting a history, thinking about weight loss, food aversion, skin changes, bone pain, night sweats, and even like potential lymphadenopathy. The workup, how do we work these patients up in the ED? It's very straightforward. We're just looking for infection here. So you're going to consider getting CBC, CMP, lactate, looking at blood cultures, urine cultures, sputum cultures. You can even think about getting stool cultures for C. diff, and then viral panels and chest x-rays. Treatment-wise, we're always evaluating for the source of infection, but if we really can't find the source, you want to start good empiric treatment, and many times this is aiming to get good gram positive and gram negative coverage. You can also do monotherapy with like some of the drugs listed here, like cefepime. You can think about carbapenems, especially if you're thinking about like ESBL organisms, and zosyn as well. You can also consider antifungal therapy in some patients who you think are at risk for those. And obviously have vasopressors listed here as well in the setting of patients who are in septic shock and not responsive to fluid administration. One of the most important questions we like to think about is disposition. So is this patient going to get admitted or can they be discharged? And it really comes down to identifying high risk versus low risk patients, and also shared decision making between you, the patient, factoring in their ability to return to the emergency department if and when they need to, and obviously always getting the oncology team on board and making sure that they are able to kind of guide you with their insight as well. I looked at ways that we can stratify these patients in the ED, and looked at the MASC risk index for febrile neutropenia. This is a tool that's available in MD-Calc and essentially goes through different risk factors and aims to create a score that identifies patients at low risk for poor outcomes with febrile neutropenia. And it goes into factors such as burden of illness, which is actually a subjective measure that is determined by the physician, hypotension, with a blood pressure less than 90, active COPD, or chronic bronchitis, emphysema, types of cancer. You can see solid tumors versus hematological kind of give you different points here on this. Dehydration requiring IV fluids, and status at the onset of fever, whether it was an inpatient or outpatient setting, and also accounts for age. The other tool I looked at was the CISNE score, or the Clinical Index of Stable Febrile Neutropenia. And this one only includes objective data, so there's no really subjective insight from the physician standpoint. But it goes into like the ECOG performance status, which is essentially just the functional status of the patient at home, whether they are capable of self-care or not. Another one that's interesting on here is stress-induced hyperglycemia. On this calculator, it's an initial blood glucose of greater than 121, which I really do worry about how beneficial this would be in our patient population. I don't think we can. I mean, even getting a yes on that would put you at intermediate risk and take you out of the low risk group. But most importantly, I want to focus on how we can use some of these scores in the ED. So there's a paper that I found here. MRAP does a great segment on this as well. It's the application of the MASC and CISNE risk stratification score to identify low-risk febrile neutropenic patients in the ED. This study used both scores, neither of which were created to be used in the ED setting, and aimed to assess which score was more accurate, identifying low-risk patients safe for discharge. It was a retrospective cohort study, which included 230 patients with febrile neutropenia who presented to 2 different emergency departments over a 3-year period. They included patients with febrile neutropenia and individually calculated their MASC and CISNE score to see which patients had negative outcomes in a 30-day period. They classified negative outcomes as clinical deterioration during their admission, upgrading the level of care, such as going to the ICU, and positive blood cultures or death. Low risk was defined as not having any negative outcomes for up to 30 days from discharge from the hospital. The bottom line takeaway from this study essentially was, when they compared the scores retrospectively, they found that the CISNE score was 100% specific in identifying low risk for all outcome variables except for bacteremia in one case. There was one positive blood culture in the group identified as low risk by the CISNE score. The positive predictive value for identifying low risk with the CISNE score is 98% for any negative outcome. In comparison, the MASC score was less specific in identifying low risk for all outcome variables at 54%, with positive blood cultures that were recorded in about 20 patients, which was 14% of the study population. So just a summary here, neutropenia is defined as an absolute neutrophil count less than 500 or less than 1,000 with an expected decrease to less than 500. We should worry about gram-positive infection and gram-negatives, and thinking of pseudomonal infection, staph infections. Always consider the potential fungal infection as well. When it comes to workup, just remembering that you're essentially just working up an infectious process, looking at urine cultures, sputum, fluid swabs, wound cultures, and stool, and potentially an X-ray if you need it as well. and then aiming to get good gram-positive and gram-negative coverage when you're treating these patients. And finally, we discussed the mask and cysteine score with a study that really favored, with findings that really strongly favored the cysteine algorithm. Thank you guys. Thank you to the Small Talks team for all the feedback. I appreciate you guys and hope this was helpful.